Hello, my name is Dr. Maricianah Onono. I'm the Acting Director for Scientific Programs, Partnerships, and Grants Management at the Kenya Medical Research Institute. I am also a Senior Principal Clinical Research scientist who's focused a lot on doing family planning and HIV over the course of my career. My leadership project entailed me designing a digital health intervention tailored to overcome societal, behavioral, and structural barriers that adolescent girls and young women face in accessing sexual reproductive health services, focusing on HIV prevention and family planning. Why? Because we know that adolescent girls and young women have high rates of unintended pregnancies, up to 45%, and more than half of this result in unsafe abortions. Adolescent girls as well face the greatest unmet need for HIV prevention in sub-Saharan Africa. And we do know that in Kenya, for example, more than 30% of the new infections are actually from adolescent girls. And there are very many contributing factors from a structural perspective, culture, issues around access, as well as privacy in terms of obtaining this kind of services. So how did I do this work? I used a human-centered design approach. I employed the double diamond model, which has three phases: the discover, define, and develop. And I engaged multiple stakeholders, the adolescent girls themselves, adolescent boys and young men, as well as healthcare workers. In the discover phase, I explored visual appearance, the contents and the size of the kit, pictorial instructions, the app interface, and delivery protocol. And in define phase, I addressed questions such as how might we questions to refine the intervention. And then finally, in the develop phase, I adapted the content and the delivery strategies and the DHI format. What are the outcomes of this? So the figure on the left shows you what the intervention now looks like. In the discovery phase, we listened and we heard that they wanted discrete, unbranded kit packaging to maintain privacy. They wanted simplified infection, and they wanted flexible delivery protocols in terms of the riders who were taking this work there. In the define phase, we acted on that insight. We improved the delivery options. We added real-time telehealth support for guidance and emotional support as people are afraid about the results if your pregnancy test was positive, or even the need, for example, to inject the subcutaneous depot. We introduced toll-free and reverse call options to enhance accessibility. And in develop phase, we brought it all together, the instructional materials, added a component around disposal practices, integrated the counseling, and then went back to them to see if what we had designed was what they wanted. And they were able to say that, yes, it did increase the privacy, convenience, and adherence potential. So how does this intervention differ from previous prototypes? One, we've enhanced privacy and discretion. Two, we have education and psychosocial support integrated. We provide real-time telehealth consultation for guidance and emotional support during self-testing and product use. Previous models have only used text messages. We also have customizable delivery times and locations for discrete receipt of products. A lot of people have not innovated in this particular aspect of the delivery. And in terms of accessibility, we have toll-free and reverse call options to address data and network limitations. In reflecting on my own journey, this particular leadership experience and this working on this project allowed me to develop empathy, collaborative skills through stakeholder engagement, enhance my capacity to lead cross-functional teams in complex settings. And I believe that this work has laid a groundwork for scalable, transformative, integrated family planning and HIV digital health intervention solutions for adolescent girls and young women. I am truly grateful to the WomenLift for this opportunity to increase my leadership capacity. Thank you very much.